Good morning, good afternoon, everyone. I'd like to introduce Hala Jassim Al-Musawi from URC to begin today's USA TB Care 2 webinar.
Thanks, Fer. Hello and welcome, everyone. Thank you so much for joining us for today's webinar on TB administrative infection prevention and control strategies in the time of COVID-19. We will be sharing some lessons from China and South Africa. My name is Hala Jassim Al-Musawi. I'm the Activity Manager for TB Care 2, and I will be moderating this session. This webinar is organized by TB Care 2 in partnership with NTB Transmission Initiative, ETTI. TB Care 2 is USAID funded project and has been engaged in infection prevention and control activities with USAID funding since the start of the project in 2010. We appreciate USAID support for ending TB around the globe. Just a little housekeeping before we get started. If you have any questions or comments during the webinar, please type them into the question box in your Zoom control panel. We will have a time for questions and answer session at the end of the presentation. And also please feel free to send in your questions through the question and answer, and we will address them during the presentation or after that as well. We have a very accomplished panel to walk us through the major issues around TB administrative IPC control strategies. We'll start our webinar today. We'll have two presentations. One will focus on or provide an overview about TB administrative infection prevention and control strategies for COVID response, lessons learned from South Africa. This will be facilitated by Dr. Matsi Mamfale. I will introduce her to start the first webinar. Dr. Matsi is the Infection Prevention and Control Advisor for TB South Africa, a project managed by URC, providing technical support and coordination of IPC implementation. Before joining URC, Dr. Matsi was the Implementation Science Director at JPS Africa, responsible for readiness assessments for decentralization of MDR-TB services of various health facilities in South Africa. She previously worked for South African Medical Research Council, managing the laboratory, overseeing rapid SDR TB surveys, conducting studies to test various interventions for infection control, also training on TBIC and laboratory biosafety. She is currently the co-chair of the Union TB Infection Control Working Group and also core group member of NTB Transmission Initiative of the Stop TB Partnership. Dr. Matsi, please start. Thank you.
Thanks, Hala, for the introduction. Good afternoon, evening, and morning to everyone. Okay. Okay, this presentation gives an overview of TB administrative control measures that can be leveraged in response to COVID-19. So in my presentation, I will give a brief background on different strategies to reduce the spread of COVID-19, talk about the hierarchy of IPC controls as an integrated package of IPC, share examples of how the admin controls have been implemented in South Africa in response to COVID, including FAST strategy, and talk about the overall performance in FAST size, showing the benefits of implementing FAST, and also talk about monitoring implementation of IPC. I'll also touch on infection prevention and control at household level, also highlighting TB and COVID screening in the community, and also share some lessons learned. So COVID pandemic has affected the TB response in South Africa and so many other countries. In South Africa, TB notifications have gone down. Average weekly gene expect testing volumes have decreased for TB has decreased by 48%. Weekly number of persons tested positive for TB declined by 33%. And this is not due to lack of lab capacity, but what has also contributed is limited movement during lockdown, and thereby access to services was a challenge, and also non-availability of transport. TB has so much to teach us about the tools that can help to mitigate the current pandemic. Already, we have, as the TB program, there are skills and knowledge that we can tap on to mitigate the crisis. An example is the importance of infection control to reduce the risk of nosocomial infection, active surveillance, triaging in healthcare settings, cough etiquette, rapid testing and diagnosis, isolation of patients, treatment, contact tracing, and also public awareness. Also, the importance of community participation and other congregate settings to raise awareness, prevention, and also for early notification in COVID-19. Collaboration is also important. Collaboration between different programs, HIV and non-communicable diseases. So TB prevention and control consists of a combination of measures comprising of administrative controls, environmental controls, and respiratory protection, which must be implemented as a full package, but giving priority to the administrative control measures as the basis for reducing transmission of tuberculosis. These administrative control work practices are intended to reduce the risk of exposure to persons with infectious TB. So they are the first line of defense and have the highest impact. These include cough screening, cough etiquette, separation, fast tracking, prompt diagnosis, initiation of treatment once you've identified patients with TB or COVID, and ensuring that the services that we provide are of good quality, they meet the global standard. Staff HIV and counseling and testing is also important. Training of staff, education is also important. And the second line of defense is environmental controls. These are important to ensure safe ventilation. And the third level is use of respiratory protection. Managerial measures are also important in terms of overseeing implementation of IPC, and these will be the establishment of infection control committees and making sure that TB infection control officers or coordinators are appointed in writing, as this usually gets overlooked, and you will find that the infection control officers, they're given other responsibilities. And also risk assessments and development of facility plans. So in the next few slides, I will be giving examples of administrative control measures that have been implemented in South Africa. Risk assessment is an important exercise to identify specific problems or non-compliance in terms of infection control, that may expose you to TB or COVID. So IPC measures that are to be implemented and even the resources that are to be used for facilities are informed by the risk assessments. So risk assessments have been conducted to evaluate preparedness of the facilities for COVID, prevention and control, and also, ensuring that we adhere to the standards. We have the guidelines, we have the algorithms, so it is to ensure that we adhere to those. In South Africa, we do not have a standard risk assessment tool. However, provinces have been proactive and have come up with an integrated tool for dual purpose of ensuring that both COVID-19 and TB is included. The tool looks at the state of infection prevention and control compliance, which is reported in the form of a dashboard, where you will either have things in place or partially done or not in place at all. And thereafter, an integrated plan and SOPs are developed, and that outlines a protocol for prompt recognition of these patients and separation, making sure that you do not expose patients who are well to those with infectious TB or COVID, provision of services, and also investigation of COVID, and ensuring that the referral pathway it is clear, and also development of quality improvement plans based on the gaps that have been identified during this assessment. So this is an example of existing mHealth technology that can be used in the fight against the COVID-19 to monitor IPC compliance. IP Connect is an initiative of the Department of Health in South Africa, and it is implemented through the TB South Africa project. It is a digital app with a platform, among others, for risk assessment, and it includes COVID, it includes also other platforms looking at CO2 monitoring. So this is a zero rated application that is free of charge. You will be able to see the dashboard. It is live, and of course you'll be able to see the list of your facilities that you have assessed, and be able to get the reports immediately. You can share with the facility that you are assessing. And also it has the ability to flag the areas that need to be followed up. An example on the far right-hand corner is monitoring of infection control measures over time. I have selected just 2 indicators there to show that if you monitor and give feedback to the facilities, there's definitely some improvement that can be seen. I've looked at infection control plans and also the IPC guidelines. You'll see that in 2018, they were at 64% in terms of the plans that, in terms of the facilities that had plans out of those 11 that were analyzed, and that has improved to 88%. Sharanya, I'm not sure what happened there. I don't see the next slide. Okay. This is the next slide. So this highlights, again, the importance of monitoring progress and paired with regular feedback. As I have mentioned, you will see that at baseline, these facilities were mainly RAID and activities were partially done. But as you monitor and provide support to these facilities and ensure that they do comply, by the end of 2019, most of these activities were green, except for UVGI, of which we still have the moratorium in place for UVGI. Okay. This slide highlights the importance of training staff on new knowledge, making sure that they are updated on new guidelines, and also monitoring of adherence, which is important to achieve successful implementation. I've just shown some pictures where we've been training community care workers and also staff from the facilities. I'm trying to project fully. Sharanya, can you please assist with that?
Hi, Matsi.
Yes, Imran, can you project fully?
Yeah, sure. If you just go on your bottom right-hand corner, if you do slideshow, then it will go to.
There's nothing there.
Okay, press F5.
Matsi, maybe actually would be easier if you just stop moving your screen and I'll take over.
Okay. So
Yep,
you can, yeah, you can move to the next one.
Yep.
Just after the capacity building is. Go to the next one. Yes, we can move here. Okay. This is also part of capacity building of healthcare workers. Here, we continue to conduct fit testing or train healthcare workers on fit testing, which is important for both TB and COVID to ensure that the respirator fits and seals properly. So potentially contaminated air cannot leak into the respirator. What we've also learned is to develop a supportive culture. A few weeks ago, Paul Johnson mentioned something about having buddies. So that is quite helpful, so that where we notice someone hasn't worn PPE properly, you can point it out to that person without embarrassing them. This also came with challenges during COVID. It has been, one of the most difficult control measures to implement, the way issues around contamination of the wood and healthcare workers, did not feel safe using it. So we had to take them through the whole process and also showing them how you can clean after it has been used. So what usually happens, because at times during COVID, it's difficult to fit test everyone. So what we've been doing, you would train key personnel that would have to fit test the rest of the team. We can move to the next one. And then we have also trained them on how to do seal check properly. One thing to mention with regards to fit testing, what facilities are also doing to address their concerns of contamination and whatever. So what they do is to say, perhaps per day, they would take a few healthcare workers to fit test, maybe 2, so that during the day you can clean your hood and aerate it after you have sprayed it with alcohol. So that has worked quite well, or aerate it overnight. So you just have to do a few of those. So with regards to respirator seal check, I think it is important to mention that this does not replace fit testing. It is also required that after you have put on your respirator, you still have to check if it seals properly. And of course, we have something that we call it's a positive pressure check, where you exhale and ensure that there's no outward leakage at the seal, and also the negative pressure where you inhale. And of course, what you're expected to see is the respirator will collapse slightly. We can go to the next one. On this one, I will give a brief overview of the FAST strategy, which is an acronym. FAST stands for finding cases actively, separating them safely, and making sure that they are treated, those patients that you have identified are treated effectively. In South Africa, it is hospital-based. We haven't moved to the clinics. The general approach is to screen patients as they come, you screen them for TB. You diagnose, using rapid tests. We use GeneXpect and make sure that once you've identified the patients, they are put on treatment. Also, triaging and separation of these patients and is important. And also, in the time of COVID, we have found this very important. As we continue to roll out screening for COVID, it is important that we do not forget about TB, as this patient can also be found in different wards of the hospitals. We can go to the next one. A little bit about coverage, where we are in terms of implementation of the strategy, which is also an administrative control strategy. We are in 5 provinces of the 6 that are supported by the project. We have moved from 15 facilities to 154, of which 86 are directly supported. We have implemented training of trainers, which has worked well to ensure sustainability and making sure that that training gets cascaded to other facilities. What is also key is the integration of LF-LEM for case detection of TB in HIV patients, and also integration of quality improvement, continuous quality improvement to address implementation gaps that are identified. Some of the successes are detection of unsuspected cases among key populations in areas where you would not ordinarily screen for TB. We can move to the next one. Okay, this is an example of how screening is done, where FAST is implemented in response to COVID. Queues are managed from the gate using a zoning criteria. We address patient flows to avoid mixing of symptomatic patients with vulnerable patients. Of course, social distancing is observed and temperature is taken from the gate. At the bottom far right is a picture during FAST launch, where I think there's another picture missing, but in any case, what I'm trying to say here is that even before COVID, in the FAST sites, this fast tracking has been happening, and screening has been done at the gate, where security personnel will observe as patients come through the pedestrian gate and see if there's anyone that is coughing, and they will hand out the surgical mask and direct that person to a screening area. And then in terms of the current situation with the zoning of patients, the yellow zone is just your starting point. You will see the picture on the right. You have markings on the floor. This is your first screening station. And then if you are symptomatic, you move to the next one, your orange one, you are directed there. And if you have none of those, of course, you will go to the blue zone. We can move to the next one. So as we continue to expand screening for COVID-19, I've mentioned that we should not forget to screen for TB patients, or we should not neglect it at all, because these are patients that are also at risk for TB. This is a tool that is used for both COVID and TB. It is an integrated one, but it is not used nationally. We see the benefits of doing that. A number of patients have been detected through using this tool. We also have an app for COVID-19. This can be downloaded on your phone, and we also have a web-based tool. The report gets submitted through the app, and the results are communicated to the user and also to the district that will have to follow up and do further management. So patients that are symptomatic for other conditions are flagged, and therefore the district or healthcare workers will have to follow up. So what is nice with this tool is that it has a platform for self-screening, and also if you are already a patient, you can also declare that you are an existing patient. So maybe it is for purposes of being followed up or contact tracing or monitoring. You can go to the next one. In terms of lab diagnosis, we have laboratory networks that are well established. 90% of the facilities of the hospitals rather, have labs on site, and they do have gene expert. However, not all hospitals in South Africa are COVID testing site, only a dedicated few that can test for COVID. However, facilities screen and collect samples and then would have to send to a testing site. We have an effective transport network system, a courier system that is available, and a clear referral pathway, when a patient has been screened, swabbed, and making sure that within the shortest time possible, within 16 hours, the specimen reaches the lab. We can go to the next one. This is to highlight the importance of proper ventilation and the importance of healthcare workers wearing appropriate PPE and ensuring that sputum collection is done in a well-ventilated area. On the left, we have sputum booths that we've been using for, we use for sputum collection, and on the right, we have dedicated tents or booths where swabs are done. So ventilation, it is important, and we continue to do that. We can go to the next one. So by separating safely, what we mean is while a patient is waiting for laboratory diagnosis, patients with either TB or COVID symptoms are educated on respiratory hygiene, are counseled to address issues around stigma and discrimination, be it TB or COVID-19, and are moved to a designated, well-ventilated area. With COVID, once you are under investigation, and therefore you would be moved to a quarantine ward away from other patients to prevent further spread. On the right are just pictures showing, the spacing while patients are waiting, and also, waiting areas outside in a well-ventilated area. These are the processes that have been put in place. We can go to the next one. So this slide shows the overall performance of fast implementation over a period of 3 years. So what is presented here is TB data. We see an improvement in terms of screening from baseline of 41%, which is highlighted there, to 79.5%. And we have also seen an increase in terms of people that have tested positive, slight increase from 14.3 to 61%. The message here is we already have systems in place to screen, detect, and test for TB. So as we screen for COVID, we should not let TB. We can go to the next one. So one of the benefits of implementing the strategy or this administrative control strategy is reduced turnaround time. Loss to follow-up has reduced, treatment delays have been reduced. Between 2018 to 2020, average time from collection of sputum to, which is the graph at the bottom, to treatment reduced from 4 days to 1 day. And from diagnosis to treatment, it reduced or was sustained and remained at 1 day or just a little bit over. And then in terms of time to diagnosis from sputum collection, that also reduced dramatically from 3, almost 4 days to 0.5. You can go to the next one. So if you look at the reduced time from diagnosis, which was 4, at the time it has reduced to 1.3 by 2019. You will also see at the bottom, if you look at the number of days, 2 days or fewer, the proportion of patients that have been detected improved from 61% to 100%. We can go to the next one. So here is just to highlight the importance of actively screening in all units, department within the hospital. Even though at times we know that there will be one entry point where the majority of patients come through, there are often leakages depending on the condition of the patient when he or she is admitted. So we are finding unsuspected cases among key populations. You will see that in staff clinic, which was not routinely done, we have found 72 healthcare workers that have contracted TB between 2017 to 2019. Isolation area, we are finding even PEDS and the RV unit, and in the labor ward, a few of them, and also antenatal clinic. We can go to the next one. This slide highlights the importance of maintaining TB services, as well as for people, who are at high risk for COVID-19. Those are the people with immunocompromised system. We have seen a 3-fold increase in case detection from 391 up to 391 up to 909. We can go to the next one. In the next few slides, I will be talking about, we can go to the next one. I'll be talking about infection prevention and control in the community. So This slide highlights the work that is done by the NGOs in response to COVID-19, ensuring continuity of TB services. They have conducted door-to-door screening for both TB and COVID. So the work that is presented here is work conducted by the project-funded grantees. So last month, already 2 of the NGOs that were funded screened about 3,000 people, and 66 were symptomatic for TB. And out of those, 3 tested positive and were started on treatment. We can go to the next one. So we are finding TB patients as we continue to roll out screening in the communities as well. So this is just a month end out of the 2 NGOs. In terms of monitoring infection and control at household level, we have a tool that has been developed, where we continue to screen the contacts and refer those that are symptomatic to the clinics and provide counseling and educate patients on IPC. We can go to the next one. Just to summarize the findings with regards to the infection control at household level, the challenges that we've seen, because most of these in the communities of these houses are in informal settlement. So there are serious environmental challenges there. The households are overcrowded, and we encourage people to spend more time outside their households and continue keeping the windows and doors open. Patients live with children under 5. Under those circumstances, we also encourage them to avoid contact with them whenever possible. And then they should, the patients should spend more time outside, and of course, observe that social distancing and practice proper cough etiquette. And then under circumstances where we also have HIV positive people, continue doing the same, avoiding much contact with them and practicing proper etiquette. And where there are people who are smoking or abusing alcohol, they're advised to minimize and also are referred to social services. And we continue to educate patients on IPC and COVID. The successes that we've seen through this exercise of infection control at household levels is increased IPC awareness and, a good collaboration between social services and also the Department of Education. We can go to the next one. This is a success story from one of the hospitals that we are supporting in one of the provinces. This is the first hospital. 27 people under investigation for COVID were admitted in isolation unit. You'll remember that we also mentioned earlier on that FAST is implemented in outpatient and also inpatient department. So we are finding cases even in the areas or wards that are admitting key populations. So these people came in as referrals from household screening conducted by community workers. After admission, they were tested for COVID and all found to be negative. They were tested for TB, and 4 of them were found to be DS-TB positive, and they were all linked to CAM. That is one of the success stories that if we continue to implement these processes, we are able to reduce transmission and make sure that those people are put on treatment. We can go to the next slide. Okay, about lessons learned, political will is important to ensure cooperation from the team members. Buy-in at provincial, district, at all levels, it is important. And also implementers get empowered and they take leadership in adaptation, and also peer learning is also important. Time to commencement has been reduced and already stated, and also expansion of LF-LAM, and also surveillance among healthcare workers has improved, and we have raised awareness in terms of occupational TB risk, and also integration of quality improvement and monitoring of IPC has improved, because most of facilities were not monitoring that routinely. So whether you do it weekly or every month, that has made a difference. We've seen an improvement. In terms of challenges, there's still challenges with regards to infrastructure, and here and there is lack of commitment from staff, which results into missing patients. And also when it comes to LAM, we continue to scale up usage of LAM. There are some restrictions in terms of scope of practice when it comes to nurses. So it's mainly driven by the doctors. We can go to the next slide. Okay, I would like to acknowledge the National Department of Health and the different provincial Department of Health and all the facilities that have participated, and also our funder USAID. I think that's the last one, and thank you.
Thank you very much, Matsi. Really, this is very interesting, great results, and also very nice pictures. I enjoyed your presentation. Thank you so much. We have some questions. We'll take these questions after the next presentation. Our next presentation on administrative controls related to COVID-19 experience and lessons learned from TB hospitals in China. And this will be facilitated by Dr. Liu Yuhong. Dr. Yuhong earned a PhD at Beijing TB and Thoracic Tumor Research Institute for Microbiology and Immunology. Currently, she is Director Assistant of National Clinical Center on TB, China CDC, which is based in Beijing Chest Hospital. She's also the core group member of ETTI, of WHO partnership. She has worked for China National TB Reference Lab from 1994 to 2007, with major work on China lab network, quality assurance, and drug resistance surveillance. She has served National Professional Officer for the Stop TB Unit at WHO China office from 2007 to 2013, with focus on lab network strengthening and programmatic management of MDR-TB. Current responsibility is to coordinate the development of China national clinical guidelines on TB diagnosis and treatment, promotion of standard care in nationwide TB hospitals in China, also organizing quality assessment and technical support for TB hospital network in China. She's also implementing and coordinating a national and international collaborative project, as well as providing support to the development of China clinical trial network. Thank you so much, and it's yours, Dr. Yuhong. Please proceed.
Okay, thank you, Hala, for a very nice introduction. I think everybody can hear me, right? Good morning, good afternoon, and good evening, everybody. I think just now, Messi nicely presented the overall strategy on administrative infection control. In my talk, in my short talk, I will give you some of the example what we are doing in my hospital, Beijing Chest Hospital, to respond to COVID-19. I think before. So I don't think I can control the screen. Saraya, can you help? Can I start?
Yes, please start.
Okay, sorry. Before I go into the details, I may give you a very short background on COVID-19 epidemic in China. I think everybody knows that the first case of COVID-19 happened in early January in Wuhan, China. And you can see the number of patients increased sharply. And in February, the whole month of February, the number of the cases reached the peak. Right now, the total number of the COVID-19 patients, we have 85,000 patients and about 4,800 deaths. So after outbreak, Chinese government implement very strong approaches to respond to COVID-19 epidemic. I think the whole China, the entire society and all the departments highly involved in the responding COVID-19 pandemic, especially in our health system. So you can see from this photo is a so-called 3-in-1 health system in China. So includes CDC, including hospital and also community health centers. So the COVID-19 response actually also rely on the existing health system. For CDC in COVID-19 response, their main responsibility is to collect data, to report data, and also they perform epidemiological survey to the confirmed patients and to the contacts. And also they do environmental detection and education and guidance to the public, this kind of managerial issues. For hospitals, we have several different kind of hospitals. I will explain in detail later on. The hospital, of course, their responsibility is to treat and diagnose patients. And also some hospitals, they are responsible for screening and testing only. But for the confirmed cases, they just refer to the COVID-19 designated hospital for the further clinical service. And also the hospital also delivers some medical support to some special settings like airport, because at the second stage of the outbreak, there are some imported cases from outside China, so they need some technical support from the hospital. So this is a hospital part. For the community, they are mainly responsible for the contact tracing, contact management, especially during the lockdown of the community. They have very heavy workload. And also they do active screening for the risk population. I think today I'm going to, can I move to the next slide, please? Okay. Yeah, previous one, sorry. Yes, thank you. So if going into the hospital, because I think I just want to share some story in hospital. So as I mentioned just now, we have a different type of hospital who will deliver the medical service to the patients. In the beginning, each of the city, we have designated hospital for COVID-19. Different city have different number. For example, in Beijing, in the beginning, very beginning, we have only 3 designated hospitals at the city. And in the second stage, when the number of the case increased, we have in total 20 designated hospitals. Each of the counties in Beijing have our own designated hospital. These hospitals are mainly responsible for the diagnosis and treatment of confirmed COVID-19 patients. But some patients have the symptom, have a fever, they just come to this kind of designated hospital for diagnosis. with more and more patients come in, so they cannot just tolerate this workload. So we have, so next step, we have the decentralized screening hospital. You know, in China, just like in Beijing, take Beijing like example. Beijing, we have around 2,000 different kind of level hospitals at city level, county level, district level, and even down to the community healthcare center. So the total number is 2,000. Some of them have capacity to screen, to deliver the screening and the testing. So this hospital, the orange one, is called screening hospital. My hospital, Beijing Chest, actually belongs to this kind of screening hospital. They do the primary screening and testing. And if the patient, some patients need to wait for the result for the final diagnosis. So they have to stay in this hospital for maybe several days. Yeah, they keep the this hospital keep the patient in the isolation ward, in a special ward, and if confirmed as a patient, they can refer those patients to designated hospital. And then this, and still not enough for the designated hospital to treat the confirmed cases. So in Wuhan, they firstly established the so-called mobile cabin hospitals to treat those mild cases. Those mobile cabin hospital actually based on the conventional centers or support stadiums. They don't have very intensified healthcare equipment, but they have doctors and nurses and very basic or preliminary equipment they can provide the basic package to the patient. And if the patient has some severe symptom, they can be referred to the designated hospital in the city. So that is a patient flow in general. But in different cities or different area, there are some difference. Can I move to next slide, please? So after background, so I would like to touch in my administrative control. Here I want to say, actually, IPC is not something new for the hospital. But what we didn't know is COVID-19. We do not know how hard is that, how infectious is the virus. So we have to do some tailor or upgrade according to the new outbreak. So what we are doing is upgrade current IPC regulations and documents and material, and also train our medical staff. And also I would like to maybe talk a little bit in detail on different measures to minimize the transmission in our hospital. Next one, please. From national level, from beginning of the outbreak, from country level, Ministry of Health, China CDC, they have issued a lot of, really a lot of regulations and documents and distributed to the local. And the city level, county level, even our hospital level, we have developed or upgraded a lot of regulations. This is something I just show you some of the pictures. Also for the doctors and the nurses, we developed a lot of education material, including we translated the ETTI information sheet and disseminated to not only the doctors in my hospital, but also all over China to emphasize on how to properly use the PPEs. And also we developed a lot of things like how to guide the patient to use the masks. Yeah, this kind of things is the first step they implement. So second one, next one, please. So after we have that, so the next step is we have also to train our staff on the new IPC requirement during COVID-19 outbreak. Because of the outbreak, we cannot organize a face-to-face workshop or training. Mostly we based on this kind of webinar, or take example in Beijing, we have this Beijing education e-learning platform. Each of our hospital staff, including like myself, I have a unique ID and a unique password. We have a requested list, which is mandatory to learn for everybody, for all the health workers. So we have online course. After that, we have to do the test. If we fail the testing, we cannot get the promotion for the next year. This is a very strong approaches. All the staffs has to learn from that. Next, please. So next, I would like to mention the different administrative measures to minimize the transmission in hospital. Actually, all the measures are designed based on early identify and early separate the patient at different risks. And as I mentioned before, there are several different types of hospital in China in current outbreak, including screening hospital, mobile cabin hospital, designated hospital, and also some isolation sites. They have different responsibility, and because of the different, so they have different patients or different people coming in. For example, for screening hospital, majority of the patients coming to our hospital actually are not COVID-related patients. They may have some other system disease, or TB, or lung cancer, or even other, maybe some other diseases. But also there are some people, they have fever or some suspect symptom. They come to our hospital to screen, to confirm whether or not they have COVID-19. This is the different type of our hospital. And for the mobile cabin hospitals, most of them are actually all of them are confirmed COVID-19 patients, but most of them are mild cases. And also there are some highly suspected COVID-19 patients. They are not confirmed, but also need medical care and waiting for result for the final diagnosis. In designated hospitals, majority of their patients are also confirmed COVID-19 patient, but yeah, most of them are severe cases. And also because those hospitals are not treating COVID-19 only, they also have some other patients. In several hospitals, they have also TB patients. So you can see the different hospitals have a different combination of the patients. So the principle or the most important thing is how to early identify them, how to identify different people at different risk, and try to separate them as early as possible. Next, please. Then I will give you the story in my hospital. Before that, I just use this slide to introduce a little bit my hospital. It's a grade 3A hospital, mainly focused on TB and lung cancer. 3A is in Chinese hospital category is a top level hospital. We have total number 600 beds, 50% of this bed for TB. And also we have other public health roles, including we are National Clinical Center on TB to support National TB program. And also we are WHO Collaborating Center for TB Research and Training. Yeah, this is just a little bit of our hospital. Next, please. So what we have done when we become a screening hospital to respond to COVID-19. First thing, we set up the primary screening at the main entrance of our hospital. We have two approaches. One is for the temperature screening. You can see from the photo. Everybody who want to coming into our hospital, they have to do the body temperature tested. And also the second thing they have to do is they have to scan this code. This code is called Health Rapid Response Code. You can download from your cell phone. It's very easy to learn app, and you can easily check your health status. If after this you scan this code, if it is show the green color and say there's no abnormal, meaning normal, meaning that you never go to the high risk area, you didn't exposure to those high risk factors in recent 14 days. So at entrance of our hospital, we test the temperature, we check this code. If it's green, if it's normal temperature, so we can consider this patient at a low risk. Next, please. And then second step, we separate the patient with normal temperature and green code with the abnormal temperature or the orange code or red code. We for the abnormal temperature or the red code, we refer those patients to the fever clinic. So we set up a special fever clinic. Probably not all the patients have fever, but have at a high risk. There is an indication, clear indication to the patient who has fever, go those direction and go to the fever clinic. Of course, the healthcare workers, we go through another totally separate entrance. We are totally separated from the patients. Of course, we have to show our staff ID. Next, please. So here is a fever clinic we specially set up for this COVID-19 response. It is actually separate and or far from our main clinical building. It's in the corner of the yard. And they have, in the beginning, we have 10 beds for the patient waiting for result. And currently we have 16 beds temporarily hold the patient and provide basic health care and waiting for the COVID-19 result. And here in our clinical fever clinics, all the healthcare workers has to fully equipped with most high level PPE. You can see they are wearing the protective gowns, the shoes cover, N95, the eye cover, and also the gloves. Everything well equipped. Here at clinical, at the fever clinic, the patient, what they do, they have to repeat the temporary temperature and also do the nucleic acid test, NAT. In the beginning, we only do these two items, and in the second stage, in recent, I think after April or May, so we not only do the temperature and NAT, we also perform patient with a chest CT scan, antibodies screening, and also we do the epidemiological survey. Next, please. So another approach is to keep person-to-person distance, is social distance. You know, in big hospital, normally it's crowded with people, it's super busy. So the social distance normally is not really strictly cannot followed. But during the outbreak period, the people, they like to follow the social distance. You can see from this photo, even there is some space, they do not want to push. And also in our waiting area, we use this kind of cover to separate the seats so that the patient cannot sit together. So to keep at least 1 meter, 1 meter's distance. Next, please. So another approach, we tried everything, or we tried innovative approaches to minimize the number of the normal TB patients or other or patients with other diseases to minimize the number coming to our hospital. First one, maybe I will introduce you this app. The app, this left-hand side one is used by the doctor, and the right one is for the patient. Both patient and the doctors, they can download this app. The patient can request a clinical service from this app. They may say, I have some cough, or I have some symptom, I need to visit the TB clinic. So they just send a request, and the doctor, and they can even select the doctor, which doctor they want to see, they want to consult. And then the doctor can receive the request and give this some kind of online consultation. If necessary, we can also organize this kind of group experts online consultation meeting to make the patient to make a diagnosis, and also we can prescribe the drugs for the patients. And after diagnosis, and also for some follow-up patient, they just want to take drugs. So after clinical consultation, so we can the hospital prescribe the drugs and also deliver the drug to the patients, so that the patient are not really necessarily coming to hospital to take drug to seek medical service. Because as our hospital seated in Beijing, so but Beijing is a relatively low TB prevalence city. 50% of our patients are actually from other provinces outside Beijing. Because of the outbreak, the travel, there is a limitation restriction on travel between the different provinces. So they are not able to come to our hospital for follow-up, for taking drugs. So by doing this, they can easily get basic service and also get the drugs, so that they will not interrupt their treatment. Next, please. Yeah, of course, the administrative measures is not everything. So in our hospital, we also do environmental control, like UVGI, and ventilation, and also the health workers wear personal protective equipment. So all these kind of measures have to be used as a package together, so that we can get effective outcomes. Next, please. So what we have learned from this pandemic, from this outbreak, I think, as I mentioned just now, in our screening hospital, in our COVID-19 designated hospital, some of them are also treating TB. So I think because compared to those general hospitals, the TB hospital have more experience on working with on dealing with the communicable diseases. For example, doctors and nurses and healthcare workers, they have more sense or more knowledge or skills on infection prevention and control. And also in our hospital, or some other TB hospitals compared to general hospital, we have relatively more sufficient supply and more sufficient storage for PPE. And also we do the routine training to health workers and do the practice rehearsals on infection prevention and control. So those things for general hospital, they normally do not have those kind of practice in their routine work. So when the outbreak comes, so they think they do not actually know what is the most important thing, what is the first step, second step, and third step. So it took a little bit longer time for the general hospital to really meet the requirement of hospital infection prevention and control. Next, please. So also I think we have some lessons learned from this outbreak in terms of the infection control and prevention. Because also, as I mentioned just now, infection control and prevention is addressed in hospital, but it's not really highly addressed, especially in the hospital dealing with non-communicable diseases. They really sometimes the doctors and nurses they do not think about infectious diseases. I think for the doctors, they have to have, the first thing is to educate them to learn, to know, to understand really the infection control issue is really should be put into their daily practice. It's not something happen only when the outbreak coming. And also they have to, all the hospital, not only the communicable disease hospital, but also general hospital, they should have basic preparation for the infection prevention and control, including they have to some minimal storage for personal protective equipment, and they have to routinely conduct a refresh training to their staffs, and also need to have a very comprehensive plan or backup plan for the potential outbreak. Next, please. Yeah, I think this is my last slide. This picture is drawn by my daughter, which is a middle school student in Beijing. I like it very much. Just want to use this picture to close my talk. I really wish all the healthcare workers stay safe. Really hope everybody all over the world can stay healthy. Thank you.
Thank you very much, Dr. Young. This is really very informative and excellent presentation, and congratulations to your daughter. This is very nice as well. So we have 4 questions. We have 4 questions. I will start with the questions for Matsi. We have a question from, I think the first question from David Bryden. His question is contact tracing and provision of TB preventive therapy part of your IPC integrated package? If not, why?
TPT is part of the package as NGOs visit the households for contact tracing. Should there be any people meeting the criteria, that is your HIV people or people living with HIV or your under 5s regardless of HIV and so forth, they do refer them to the clinics. It is not offered by the NGOs, but they would refer them to the clinics, and then they will be put on treatment.
Thank you so much, Matsi. The second question from Rahul. What specific steps were taken to improve uptake for TB screening by health system, TB program, or NGOs in view of less people being screened? And this question, I think, to Matsi as well.
I think this refers after the outbreak, because in the beginning there were some concerns that the TB screening has taken a backseat. So what has happened is, remember I mentioned that we have an algorithm that states clearly that if you have any patient that is showing TB symptoms, that patients need to be further investigated. It is part of the guidelines, part of the algorithm. However, the tool itself nationally is not integrated. So provinces have been proactive. They've included that so that it serves as a reminder to make sure that if you have these people, let's ensure that you also screen for TB, they are symptomatic, and then you further manage that. In addition to that, it's just to continue to educate staff and not to neglect TB or any other diseases. And of course, just creating awareness about TB.
Thank you, Matsi. We have another good question from David Bryden. This is for your presentation again, Matsi. What proportion of COVID-19 testing in South Africa integrates? What proportion of COVID-19 testing in South Africa integrates testing for TB as well?
This, I think, links to the second one that I've just answered, that we have the algorithm and the guidelines that says that if a patient is symptomatic and is tested, that patient should also be put on treatment. So testing for the patients that have TB, it is part of the COVID guidelines.
Mm-hmm. Mm-hmm. And as I understand, and here in South Africa now, the issue is the transmission at the community level, which is a big issue, and where we have the NGOs and the community kind of
yes.
TB treatment and cares there. So it's good to get more information about this one, Matsi, and if it's available, then we can share this information with the participant. We have all their contact information now, and we can expand on the answers for these questions because all these are very good questions, and we can learn from South Africa and elsewhere. Thank you so much, Matsi. We have a question or observation from Evelyn to Dr. Yon. Just on the seating arrangement for social distancing, what happens as the patients move along the queue? And do you only use the market seats? Are the seats sanitized in between?
Yeah, thank you for the question. Actually, for the seats, so we are so in the middle. The two seats in the middle actually is covered by some film. We only use the seats outside in the right hand side and other sides. Every day we have the workers, the temporary workers, have some deficit distance for the seats, or every seat, not only the patient not only the seat in use.
Mm-hmm. Great. Another question from Shahid, if I may pronounce the name correctly. Is a slight sore throat is important to consider? Important to consider?
If I may answer that one, it is, I'm not sure there is follow-up question, otherwise not for COVID-19.
I don't think it's a follow-up question, and this is for COVID-19 otherwise.
Oh, okay. Yes, in our screening tool, sore throat is also included. You have your temperature, you have your sore throat, difficult breathing. You have, now that they have incorporated TB, you also have weight loss.
Yes. Another question, and this is related to the lessons learned from China. Great to see use of technology, mobile apps in screening and patient pathway in China. How was the system accessed by patients who might not have a cell phone? Yes, and this question from Karam.
Is the question in the box? I didn't see that.
Yes, and feel free if you have access to the chat box to respond. But that's yes, just post it now.
Okay, can you see it again, because I didn't see the question in the box.
Okay, so the question: how was the system accessed by patients who might not have a cell phone?
Okay.
This is from CDC HQ.
Okay. Yeah. Yes. Actually, the patient. So in China, I think most of the patients have the mobile phone, but the problem is some senior patients, they do not use the smart mobile phone, or they are not very good at using the different apps. So for those patients, it's really very difficult to reach. But it's not in Beijing, but in some other provinces, I know that the healthcare workers working in the TB hospital, they do the telephone interview and also to follow up the patient. And if the patient needs some drugs, so they just send the drug to the hospital, because to the patient's home, because the patient cannot coming into the hospital is a closed management of the community.
Another question from Fernando. Do you have an incidence or rates between TB and COVID-19 as comparative between both healthcare workers?
This is for China, right? For the first question, I don't think I have the data, but we didn't have the data exactly, actually, because in China, most of the COVID hospital and the TB hospital are separate. Although some hospitals are overlapped, but most of them are separate. They treating COVID and TB in different hospitals. This is number one. And second, we really do not do the statistics current stage. But from our observation, for TB patient, there is seems is low risk or low incidence for COVID-19. Is for the first part. And second part is for the health workers, right?
Yes.
For this one, we do not know exactly data, but according to the public data available at the end of March, there are around 3,000 healthcare workers suffering from the COVID-19. They are happening, this 3,000 are actually coming from about 424 hospitals. Most of those hospitals are not TB hospital, they are general hospital, as mentioned before, because the infection prevention and control in those general hospital are not in place, not really followed very well, especially in the early stage when at that time we didn't know anything about the COVID. We do not really realize the dangerous.
Yeah. Thank you so much. So we have 5 minutes, and we have 54 participants who joined this presentation. Thank you so much. And the presentation and recording will be shared to all via email. We also sent email and request to Dr. Paul. I'm not sure he was able to join, but Carrie and Grigory on the call as well. So Carrie, if you would like to expand or to add anything, same with you, Grigory, since we have 5 minutes and we have this great group of participants joining us.
Thank you, Hala, and thank you again to Matsia and Liu Yuhong for your wonderful presentations. I think it's really good to see how administrative controls can be put into practice, especially under these challenging times that we find ourselves in now with COVID, not just for TB, but airborne and infectious diseases in general. And thank you again to URC for hosting this webinar, and we hope to do more in the future, so please stay tuned, and we hope that you will join us in the future. Grigory, did you have anything that you wanted to add specifically?
I think extremely important and interesting reports from South Africa and China using existing health systems, applying our airborne infection control skills and knowledge in fight of COVID-19. And I think it saves lots of times, lots of healthcare resources. Thanks for both presenters.
Thank you so much, Carrie and Grigory. Again, as Carrie mentioned, this is one of the many webinars to come And I think there is interest to hear this by many countries, as I know. So definitely there is interest to share these, as well as to share experiences and lessons learned with other countries and from other countries. So thanks again, Matsi, and thanks again, Dr. Liu Hong. And thank you very much to all the participants who joined us this morning. Bye-bye.
Thank you.
all.
Thank
Thanks.
you.
Stay all,
Thank
Have a good
you.
day.
stay safe and healthy, you all. Thank you.
Thank you, you too.